Welcome to this podcast from the Medical Journal of Australia. My name is Sam Hunt, the MJA's News and Online Editor. Today we are discussing the experiences of Australian and New Zealand doctors when they receive disciplinary notifications or are under investigation due to alleged mental health impairment. My special guest is Dr. Owen Bradfield, the Chief Medical Officer for the Medical Indemnity Protection Society, which sponsored this podcast. Dr. Bradfield is also a medical practitioner, a health lawyer, and a 2020 Fulbright Future Scholar. He has recently completed a PhD on this topic, and you can find the link to that in the description of this podcast. Dr. Bradfield, thank you so much for joining me today.
Thanks very much, Sam. Thanks for the invitation to speak.
Let me start by asking you what prompted you to do this research, and why did you think it was important?
So as a doctor and a lawyer, I've worked in medical defence in the medical indemnity industry for over 10 years. And I guess one of the things that struck me very early on in that time, and something that they never really taught me in either medical school or law school, was the impact that legal claims can have on parties to those proceedings. And in particular in relation to doctors, I guess the impact that poor doctor health and well-being can have on the risk of claims and complaints arising. So I guess one of the things that I sort of observed was that, I would see doctors who were very highly regarded, had extremely successful careers, were at the peak of their profession, and, who had previously unblemished regulatory records. No one had sort of ever made a complaint against them, or they certainly hadn't received any claims or complaints by regulators. They hadn't been sued. And then all of a sudden they would receive a sort of a cluster of claims and complaints against them. And when you got to know them better, through assisting them in defending those claims and complaints, you would realise that things weren't going as well as they could have been in their personal lives. So, for example, they may have recently undergone a relationship breakdown, or perhaps a close family member or friend might have passed away, or perhaps they were suffering from some early cognitive decline, or perhaps experiencing some early symptoms of depression or anxiety or something like that. So I guess I sort of started to appreciate that there was this link between poor health and well-being and the risk of claims or complaints arising. And I guess similarly, thinking about it the other way around, and I think myself as a doctor, I've received complaints from patients in the past, thankfully relatively minor complaints, but, I think about how I felt when I received those complaints. And I think for a doctor, being a doctor is so central to your identity, and it's part of who you are as a person. And so when you receive a complaint, it's hard not to take it personally, and it's hard not to question, your value or your worth as a practitioner. For most doctors, they feel all sorts of emotions when they receive a claim or a complaint, sort of anger, disbelief, shock, questioning their value or their worth or their capacity to practice the profession. Most then relatively quickly accept what's happened and are able to respond to the complaint productively and move on with their lives and put it behind them, which I think is absolutely important to do so. It's important to reflect on claims and complaints and to kind of reflect on any potential learnings that might arise from a complaint. But I think it's really important to be able to put it aside, to learn from it and to move on. But for some doctors, that was incredibly challenging, and some would, develop anxiety, depression, and some would even experience suicidal thoughts. I'm sort of early in my career as working for a medical defence insurer, and I'm observing this, and I can see that there seems to be this bi-directional relationship between health and well-being on the one hand and claims and complaints on the other. And so I was fortunate enough to come into contact with two wonderful people, Professor Matthew Spittle and Professor Marie Bismarck, who are my PhD supervisors at the University of Melbourne's School of Population and Global Health. And so I then resigned from my employment and pursued a PhD. And, I think it was such an immersive and fulfilling experience, but also, really humbling. And it taught me a lot about not just the findings from my research, but I think it made me sort of personally and professionally reflect on what it really means to be a medical practitioner, particularly in these current times. There's workforce shortages, increasing levels of burnout amongst medical professionals, particularly in primary care. There's emerging technologies, medical regulators, constantly changing the goalposts. There's new guidelines, new requirements coming out all the time, new laws regulating different aspects of the healthcare field. And so it's extremely challenging for medical practitioners to navigate this space. So it was a really interesting time and, such a valuable experience.
And you conducted your qualitative analysis of your interviews of Australian and New Zealand doctors and their experience of these disciplinary notifications and investigations. Can you talk me through your method and the kind of things you asked these doctors?
When I started planning all of this was prior to the pandemic. So initially the plan was that, I might have to think about interviewing doctors face to face in different spaces, potentially, flying across the country to interview doctors. But given that I'm based in Victoria, I imagined that most of the participants in my research would therefore be based in Victoria. And then, about sort of 6 months after I started planning this, the pandemic started, and we were all in lockdown. And when applying for ethical review for my research, it became apparent that really the most effective way to be able to interview doctors was using Zoom. So really it meant that the complexion of those interviews would look slightly different, but it did also mean that there was an opportunity to broaden the scope of the research to focusing not just on Victoria but across Australia, and in fact indeed a couple of participants from New Zealand as well. So essentially what I did was I interviewed 21 medical practitioners who self-identified as having either a current or past history of mental health or substance use challenges, who had also been the subject of regulatory processes relating specifically to those mental health or substance use challenges. And so one of the reasons I wanted to focus on this, because whilst I'd observed in my time working in the medical defence insurance industry that there was this connection between poor health and the risk of medico-legal claims, one of the specific things that I'd also observed was that for some doctors who were unwell or who were experiencing these mental health or substance use challenges, it wasn't always apparent to me that the regulatory response was necessarily helpful to the doctor's health and well-being, at least not in the short term. And certainly the way in which some of these conditions were perhaps monitored, or some of the sanctions, didn't always put the doctor, who in this case was the patient, at the centre of those decisions. And sometimes there are good reasons for that, but it felt very much as though decisions were being made about these medical practitioners, but not necessarily with these medical practitioners. So I interviewed these 21 medical practitioners. I also supplemented those interviews with some interviews with medical practitioners who had specific interest and experience treating medical practitioners as patients. So they may have had specific experience working with a doctor's health program, or privately had a high number of patients who themselves were medical practitioners. So all up, I interviewed 25 participants. and asked them about a range of experiences and questions, but really, I guess, essentially trying to qualitatively understand their own experiences, personal experiences and reflections on these processes. And so being qualitative research, I used a particular type of software called In Vivo, which was used to kind of transcribe and then code and analyze all of these interviews to then come up with some key sort of themes and findings.
And let's dig a bit deeper into the impact of a ARPRA notification and an investigation into a medical practitioner. I've read some of the stories that you've quoted in the PhD. You've heard from doctors who may have psychosis or an alcohol use disorder or a mood disorder. You really got an inside look into their life.
Oh, absolutely. Look, I think there were really some key findings from my research. So I think, first of all, what probably struck me the most when analysing these interviews was that overwhelmingly the participants told me that although they were aware that they weren't feeling well, and in many cases had previously had an existing history of mental health or substance use challenges, many told me that they knew they were unwell or becoming unwell, but that they delayed seeking care or delayed accessing treatment because they were scared. And primarily they were fearful that if they went to see their health practitioner, that their health practitioner would then notify the regulator about their condition. So because of that fear, they delayed accessing healthcare, and invariably their health challenges worsened. So by the time they came to the attention of the regulator, they were sometimes quite unwell. And as you point out, some told me that they were acutely psychotic. Some were found sort of wandering the streets. Others had perhaps accidentally or intentionally overdosed. Others had very severe depressive illnesses and were required, which eventually required sort of inpatient treatment for extended periods, involving, multiple sort of cycles of ECT sometimes in some cases. This particular cohort that I interviewed, in many cases, were very unwell at the time that they were notified to the regulator. When I then asked them, what do you think some of the barriers were that prevented you from accessing healthcare sooner? As I mentioned, sort of fear of being notified to the regulator was definitely the most frequent response. But others were also concerned about stigma, felt that, whilst it's okay to talk about depression within the medical profession, perhaps it's not as easy to talk about psychosis within the medical profession, and really felt a sense of stigma and shame associated with their diagnosis. And I guess leading on from, the fear of regulatory notification was, a fear of perhaps financial concerns. So, I think of a couple of participants who had a mortgage, had private school fees, and were very much concerned that if they lose their job, they would have to remove the children from school or maybe sell the house. So, some very real concerns that I think led to many of the participants fearing being open with their health provider about what was going on for them. Some also talked about just actually not being able to access treatment, or at least not being able to access confidential treatment. So for some doctors, and particularly for rural doctors, and this is certainly consistent with the literature, for many doctors who work in smaller regional settings, they and particularly if they worked at the local hospital, they didn't feel comfortable presenting to the local hospital if they needed assistance, because they would be concerned that everyone would then find out about their health condition. So there were a number of barriers that really prevented a lot of these doctors from feeling safe coming forward and accessing healthcare. I mean, I think as doctors, we're always told every doctor should have their own GP, and I think absolutely that's correct. But I think what my research sort of showed and tried to uncover was that, it's not as simple as that. It's one thing to have a GP, but then it's another thing to think about how, as a profession and how, as a society, we create systems that, on the one hand, protect the public from doctors who may not be functioning at their best, but on the other hand, do so in a way that doesn't discourage those doctors from accessing healthcare.
And Dr. Bradfield, when you got to the end of your interviews and you asked these participants, okay, what did you learn? And were there any positive takeaways? What were some of the things you heard then?
Interestingly, for most participants, there were both positive and negative implications for them. So in terms of the positive implications, many doctors, many of the participants talked about, finally getting their problem diagnosed and then being able to focus on staying healthy. And many said that, they would have struggled to do that on their own. Others sort of talked about how when they were really unwell, they weren't making good decisions. And so, although they feared talking to their health practitioner about their condition, they also realised and recognised later on that actually they were quite unwell at that point in time. And so they weren't making the best decisions. And so felt like the fact that a notification was made about them, that in fact they actually needed a bit of carrot and stick were the words that some participants used to help them overcome some of the problems that they were experiencing. For a number of others, they also talked about how getting their conditions diagnosed or getting their condition treated was really positive for their health, and saw that as a positive thing for their patients as well, because it kept their patients safe. So many talked positively about their experience, but interestingly, many talked positively about it when they look back and reflect on it some time down the track.
And Dr. Bradfield, how stressful was it for participants who were going through the process of being investigated or looked into by the regulator?
But interestingly, many talked about just how stressful it was when they were going through the process. And so some of the most stressful aspects of going through the process were really related to the delays. And so, in my experience, I think it's safe to say that the regulators in Australia have certainly improved their performance significantly in this area, and the average time to resolution of regulatory complaints now has declined and has steadily declined over the last 12 months or longer. These interviews occurred a couple of years ago now and related to experience that perhaps occurred a couple of years before that. So, with that in mind, I think it's still sobering, though, just the fact that for many of these doctors, it took so long for an outcome to be reached. And so many talked about how their mental health was worsened specifically by the prolonged nature of the investigation. Others talked about feeling like there was a real lack of empathy or understanding of what they were going through, and that they felt like they were treated, well, in one participant's words, I felt like I was treated like a junkie rather than as a person. And so I just thought it was interesting because as medical practitioners, we're all taught about the importance of patient-centred care and treating our patients respectfully. And yet, interestingly, when doctors are patients, they also expect the same thing from their regulator. And in many, for many participants, they felt that aspect of these regulatory processes was missing. So for some, the stressful nature of these investigations resulted in their illness relapsing. And for some, it was specifically because their story and their diagnosis became public knowledge, and many feared that. Some felt re-traumatized. So for some doctors, one of the reasons why some doctors experienced poor health was because of stress at work, and particularly for doctors who work in accident or emergency settings or in intensive care settings where they are frequently dealing with patients who've suffered traumas. They felt that going through these regulatory processes was very much re-traumatizing. So there were a number of psychological impacts. There were also some sort of adverse non-psychological impacts as well, if you like. So I think one of the most frequent responses was that for a number of participants, they felt that the regulatory process had really turned them off medicine. They'd lost interest or motivation to continue with a career in medicine. Others were concerned about privacy. They very much felt that they'd seen their GP for the last 10 years, had a good relationship with their GP, but then all of that health information was then sort of dug up and uncovered by the regulator, and they very much felt that as quite an invasion of their privacy. So it was really interesting. So I mean, I guess to summarize all of that, it was very clear to me that the fear of the regulatory process was a big factor in why many doctors delayed accessing care and support when they needed it. But then, having been through a regulatory process, there were both positive and negative implications for them. But interestingly, when I asked participants, well, look, if you were to become unwell again in the future, would you do anything differently? And what, perhaps the other thing that really struck me with my research was that many participants told me that despite finally being diagnosed with a condition they didn't know they had, or despite finally getting treatment for symptoms that they knew they'd had for some time, many told me that if they became unwell again in the future, they would either try to seek treatment anonymously or go overseas and get treated.
Wow. So some felt that they had to go overseas. And that really goes to one of your findings about the regulator having a more therapeutic approach where doctors can be treated more as patients while they seek help for overcoming some of these conditions.
Yeah, definitely. So, I mean, I guess part of, in conducting this research, part of what I did was to look at overseas models and how regulators interact with unwell doctors overseas, and in particular, thinking about what happens in the US and Canada. So in North America, it's quite a different model. So, for example, each Canadian province has its own physician health program, and those physician health programs, many of which are operated by the regulator, but operate sort of at arm's length and independently of, I guess, the regulatory processes of the regulator. And so what that means is that the care and management of the doctor is undertaken in a therapeutic context by a specialised physician health program that has the knowledge and the skills and the expertise to be able to assist that doctor. So essentially the therapeutic component of that doctor's care is separated from the regulatory aspects. And I think that's a very different way of thinking about it.
And some of the participants in your research came to the awareness of the regulator through mandatory reporting. So how important is awareness of that mandatory reporting process and clarity of that process?
You're right. Many participants in this research came to the attention of regulators because of a mandatory notification. And so, listeners will probably be aware that in every state in Australia, except for Western Australia, a treating practitioner must report a practitioner who is practicing with an impairment and who has placed the public at substantial risk of harm. And so obviously it's very important. I mean, that mandatory obligation exists primarily to protect the public. But what my research showed is that for many practitioners who were reported to the regulator, it's it's not something that should be taken lightly, because a notification also has significant implications for the doctor who's subject to the notification. And so I think it's really important for practitioners to understand exactly what their mandatory reporting obligations are. It is a very high threshold, and the medical board is frequently telling us, and there are guidelines that exist that help to guide practitioners around when to make mandatory notifications, what the expectations are, and what the national law requires. But I think it's really important to be very clear what those thresholds are. So, importantly, having a mental health or substance use challenge or disorder is not the same as having an impairment. Similarly, a doctor may have a significant mental health challenge that may impact on their capacity, but if they're not practicing, they can't be placing the public at substantial risk of harm. And so I think it's really important to understand that there's a difference between illness and impairment, and also that the impairment has to place the public at risk of harm. And also what's important to understand is that, so if a doctor previously practiced whilst impaired, and even if they previously placed the public at substantial risk of harm, if they are now no longer working or no longer placing the public at risk of harm and are receiving treatment, receiving support, they've been diagnosed, they're in a treatment program, then that again doesn't trigger the mandatory reporting requirements. So I think it's really important to understand very clearly what these obligations are, because as the board keeps telling us, and certainly as we tell our members, it is a very high threshold. And I think it's important as well to think about. I think it's also important if you have patients who are doctors, and if you're concerned, to have a very frank and open conversation about what those obligations are, even if it is to reassure patients that, it is a high threshold.
And Dr. Bradfield, I want to also touch on, what do you intend to do with your research and your results now that your PhD has been published?
It's every PhD candidate's sort of fear is that, this time and effort that's gone into generating data, generating results, talking with participants to get those results. You publish a thesis and then it ends up on a shelf or in a repository and no one ever reads it again. So I feel very fortunate that, in my current role as Chief Medical Officer of MIPS, that I'm really in a unique position to draw upon my research findings and to really, I guess, translate that knowledge into action. And so I feel very fortunate. I'm in a position where I can go out there and talk to practitioners about their mandatory reporting obligations and try and help members and practitioners and the profession better understand what those obligations and requirements are, just so we get that balance right. But also, I think it's also really critical that that we have meaningful relationships with the regulator. And so, I think one of the things that's really struck me is that, I think earlier this year the regulator also generated some data and some findings where they found that, I think between 2018 and 2021, 16 health practitioners died by suicide whilst under regulatory investigation. And so I think there is now a real push and motivation on the part of the regulator to try and make these processes fairer and to make the process more therapeutic and to better understand the needs of those practitioners who are going through these processes. It's been really heartening to see the regulator actively interested in the views of medical defence organisations and the profession to how we can all work together to make these processes better for everyone, so we can continue to protect the public whilst at the same time ensuring that the process is fair, appropriate and reasonable for practitioners.
Dr. Bradfield, thank you so much for your time today.
Thanks very much, Sam.
My special guest has been Dr. Owen Bradfield, the Chief Medical Officer for the Medical Indemnity Protection Society, which sponsored this podcast. Dr. Bradfield is also a medical practitioner, a health lawyer, and a 2020 Fulbright Future Scholar. You can find a link to his PhD in the description of this podcast. And you can find more podcasts on our website at mja.com.au or wherever you get your podcasts. Thank you so much for listening.